Thank you, everybody. First of all, I want to thank you, the Dental XP family, because I'm very pleased to be here. For me, it's such a honor. So, Socket Shield, what's new and what do we know? We have very short time. So, as we heard in February at the Fort Lauderdale, there are two kinds of treatments: evidence-based techniques and cowboy techniques. So Socket Shield mainly is still a cowboy technique. So we are trying, the people that named Maurice, Howie, Chuck Schremer, Armando Ponzi, and many people here, we are trying to do this to get out of the cowboy technique classification. So, because I have very short time, I begin with the conclusions of my presentation. This is very important. The first one, we have a 10 years follow-up of this technique because the Greek guys begin in 2006. And at first we thought that it was a very difficult technique, that it has a very long learning curve. But you know, everybody who is speaking about Socket Shield, after he goes off the stage, many people come here and say, I have done 5, I have done 10, and I'm very pleased with this technique. So there are very few problems and a lot of success. So we are changing our idea about that this technique has a fast learning technique. Second, to flap or not to flap. This is, later I will explain, but the conclusion is better not to flap, to do a Socket Shield. The third, if we compare the socket grafting illusion in the molar area against a molar Socket Shield, always choose molar Socket Shield, as I will show you. And at the end, we know now how to treat failures, because any technique has its own failures. So, which are the failures? The first one, loose shields. Second, external shield exposure. And the third one, the lack of integration. Okay, because we have done the conclusion, now we can play a game. The game is, where is the implant? So, we have to think, where is the implant here? The canine is a natural teeth, but lateral, central, and the other is a pontic. So, where is the implant? You have to lose and think. Okay. There were 2 implants. Wow. Why we are surprised? You see, there were 2 implants together. Look at the bone levels and look at the inter-implant bone level. And you know, this is no one abutment, no one time. Wow. Incredible. Because the shields maintain vascularization. And think about this. When I spoke about periodontum, what do we think about periodontum PDL is? We think about fibers. Because we are dentists and we are taught about fibers. But the most important part of the periodontum, seen in this article of Matsuo and Takahashi, is this organization, the network that is behind the periodontum. So when we extract a tooth of the socket, we are extracting and destroying the vascular connection between the gingiva and the socket itself. So this is a Volkmann's it's a whole canal, and you can see the connection between the bone and the periodontum microvascular network. See, so now these empty spaces that I am showing there, this is the microvascular vessels. But on the outside, we don't see, you can see, so many. That's why it's so important to maintain the PDL. So, another game. Where is the implant? The implant is here. Here we can see a typical socket shield evolution and treatment. In this case, we have done also immediate load. Look at these beautiful images. We love the emergency profile after 4 months, where we decide to do the final impressions. And so we have to customize the impression abutment to copy exactly what we have maintained and preserved. We haven't made it. It was already there. We have just preserved it with this technique. See the image at 1 year. The evolution is perfect. And if we have to see the CBCT images, there's always the question, what's in there? What is between the implant and the shield? So I have just posted 1 week ago a case, because when our cases of immediate load, I don't do this. But in cases when I open a flap, look at this case, we have to do all implants in the maxilla, but I try to maintain the bone just to preserve the profile. So when I re-entry after 6 months, what I am trying to see is that the bone is perfectly maintained, and I'm probing between the implant and the shield with this result in tooth number 8, number 9, number 10, 11, and this is the result. So the 3 millimeter distance is like a normal probing that we have when we do an immediate implant. Think about if we don't do socket shield, if I just extract the tooth, I will see more or less 3 millimeter of probing of soft tissue. This is perhaps my oldest case, a 3-year case, and you see where it's well maintained, the buccal wall, and the tissues are perfect. What are we looking about the tissues? The texture, the color, and the size, and the contour. And it's really intact as it was at the beginning. But if you want to see a beautiful case, for me the best in the world, is a friend of mine, Hakon Kuyt from Holland. And think about that you have to take out this number 8 incisor. Look at the CBCT. If you extract this, what amount of bone do you have there? And what you can do in a girl with a high smile line. So he did the socket shield, and he do immediate load, and he tried to keep the crown to do a provisional, and he is showing us what important is to give a contour here, a concave part, just to avoid, as Howie has told me on the early days, not to pressure the seal with my crown, because you cannot make a space to the tissues to come here. And look at the results. The final crown at immediate 3 years later. Beautiful results. 5 years later. Wow. So the cowboy technique is going well because it's preserving. I don't have these results with guided bone regeneration, connective tissue, because sometimes the connective tissue grows more, sometimes retracts, but here we are testing worldwide around that there is a stabilization of the tissues that continues in this way, like a nice result. To flap or not to flap, here we will see the evolution of the socket shield technique. In 2006, Siormpas and Mitsiadis begin with the root membrane technique. 2010, Dr. Hürzeler, he moved the proof of principle with doing in one dog. 2013, Baumer, the group of Dr. Hürzeler, they do the socket shield, the first histological, clinical, and volumetrical observation, and he gave us those beautiful images. You can see here that the implant is touching the shield, but between them there is bone. So never is the implant touching the shield because it's always bone between them. Interesting. Also, look at this. He told us that if we have a crack, a vertical crack on buccal side, we can do a socket shield preserving both sides. And there is bone growing inside. Later, Dr. Joe Kahn, in 2013, he had the idea, if we have a little root, periodontum, maintaining the buccal bone, can we preserve the interproximal bone? And he did one case of interproximal socket shield, and it was a success. Okay, then 2014, Glocker, he did an idea to say, okay, what do if we do a socket shield, but we don't put the implant in the same moment? Can we preserve the bone, the buccal bone? And he did this, and so this is the philosophy of bone banking. You know, I use it a lot, and Howie also, Maurice, because sometimes my patients, the tooth are aching, and he wants to extract. In Spain, the people wants to extract the tooth, and he doesn't want to think about in the moment what is he going to do in the future. He just wants to extract the molar or the incisor, and after 3 months, he said, oh, I don't like this prosthesis, removable prosthesis. Can I do an implant? Yes, but the bone is lost. But if I do, like Glocker idea or Howie's Pontic shield, you can maintain the profile of the bone, and then in the future you can use this place with the buccal bone completely intact. Somewhere between 2013 and 2014, we changed the original technique of Dr. Hürzeler because we will begin doing a mesiodistal cut, not a hole in the center, to remove this. Later, in 2014, I did one of the first socket shield on molar because by that time we thought that this was an idea, a technique to preserve the buccal bone on aesthetic cases. But someone at the dental forum said, no, I need to preserve bone everywhere in my mouth. Why should I like to waste bone? So the philosophy is to preserve the bone in the whole mouth. So it is well recommended a socket shield molar. After that, Chuck Schwimmer and Armando Ponzi, they think about why should we waste the palatal bone. And so they did a 3D, like they said, 3D socket shield. Maurice Alama came to Madrid in 2015, and we have the idea, but by that moment, we were worried about the external shields exposure. So he thought about doing a flap, and so we began doing open flap cases. But the conclusion is, we only flap when bone sounding is not clear enough. Never in extreme thin cortical plates, canines and upper incisor. Because in Spain, not always we do CBCT scans for one tooth, not always. And we have done many shields without sockets. This is the conclusion, because there was no bone at the beginning. The teeth was firm, but we thought there was bone. Okay, in the molar socket shield, this is very interesting to see the article of Dr. Matarazzo and Siciliano. The name is Dimensional Ridge Alterations Following Immediate Implant Placement in Molar Extraction Site. A 6-month prospective cohort study with surgical reentry. This is important, the surgical reentry. What happens, we open just to see what happened. They did 12 cases, and the idea was that they have to be between teeth with good keratinized gingiva and with primary stability. All the cases, the 12 cases. Okay, they insert the implant, and then they did a perfect guided bone regeneration with a low resorbent material, like BioOs, it was in this case, and with a very good membrane, BioGuide. Okay, bad news. We have bad news. This was the beginning. look what they have at 6 months. Very, very different. See the comparison between the buccal bone and the lingual bone with what we have obtained here. A lack of tissue. Look at this. The re-entry, the surgical re-entry. This size is the same like this, but there is less bone. What is the conclusion? They have a conclusion. They measure a point external crest and internal crest and the implant. And they measure the distance from external crest to implant, so they can have these conclusions. And they say that when the wall thickness between point EC to IC, when the wall thickness is 1 millimeter thick, after 6 months, we have lost from 5.17 to 2.5. We lost a lot. But when the wall is 2 millimeters thick, from 6 millimeters, the distance from external crest to implant, we have 4 millimeters. In conclusion, if we do guided bone regeneration, we lost between 50% to 33% of this distance. That we cannot avoid the consuming of the bone, the resorption is not, we cannot stop it. We can just a little fill in the socket, but we are not stopping the resorption of the external wall. Okay. Here you can see a typical case of Armando that posts every week at the dental forum, and that inspire us. You see, he does external, the external roots, the buccal roots, the socket shield, the internal part also, and he inserts molar, the implant at the middle and the septum, and he also does sometimes sinus lift with the ossification burrs. So the result is that the place is preserved perfectly. This is my first molar socket shield, and you do it. I was planning to change that crown, old crown. I cut the crown, and when I extracted it, it was loose. Almost the palatal root came. So I thought, what do I do? So I just preserved the buccal roots, do the shield, and did a customized abutment to preserve the emergency profile. And after 4 months, look at this beautiful emergency profile that we have, maintaining the buccal wall. And this was one of the first molar socket shields in the world. So, how do we manage failures? Loose shields, external shields exposures, and lack of osseointegration. The first one, loose shields. After 3 months, I found these images. I left 2 socket shields, but at 3 months, there were loose shields. Here, resorption on the buccal wall. Why? Because my improper preparation. Because the canines were inclined to buccal, and I thought they were correct, and I prepared very, very short socket shields. So, but think about, this is a failure. Yes, it is. But if you were planning to extract the canines and you just do socket shield, now you have a failure, but you were planning to extract the canine. So what do you do now? You just graft a little, put some PRF, and you finish the case as you were planning. But this was not a disgrace, a big disgrace. You tried to save, but you couldn't, okay? Sometimes happens. How many times happens this? 2 cases in 110 cases. 2 times, only 2 times, and on the same patient. So it's 1.8% a problem. And the problem is not that big. External shield exposure. Yes, this is a problem because sometimes you do the socket shield, and sometimes after wearing a prosthesis for about 4 months, the patient thinks and touches, like in this case, here, a little bit corner, something that is pinching, and this is the root that is going in the outside. So we know exactly how to manage now, because at the beginning we put anesthesia and tried to green with a burr, with a high-speed burr, with a round burr, the corner of the shield. But we destroy a lot of keratinized gingiva. There is a mark. But now this is the method to do it safe. We do a little flap, as suggested Maurice. We green the root to the bone, we suture, and you see the result. This was the case with the big depression in the middle. And you see there is no scar to see. Another contraindication is that you cannot do socket shield, not even RST, submerged technique with loose roots. So in this case, we do socket shield on the laterals, we put the implant, but after 3 months, we have a failure of osseointegration of this implant. So what happens in those cases? The external bone remains perfect. You just take out the implant and clean a little and put another implant. So it's better preserved the place, and the implant is now on the same place. After 3 months, I noticed that the shield was exposing because the management of the site and a little bit shrinkage of the gingiva. I noticed that I was looking at the shield. So I did the same. I make a little flap, prepare, do the sutures, and after finishing, you can see there are no scars on the places. Okay, this is the general conclusion is that the cowboy technique is getting older. We are doing worldwide. Many people in the world is practicing this technique, and the philosophy is that it's better to maintain and preserve the bone with the vascularization, leaving the root. I know this is a weird technique because at the beginning in 2010, when I read about this, I was surprised and shocked. I said, this is not possible. This is going to have a lot of problems. But the conclusion is that it's not. It's easy technique and it's always working. So we have to change sometimes our minds because the reality struck in our faces. This is the truth. It is working. So let's think about that socket shield, pay attention, because in the near future, PET philosophy is going to change our minds and our daily practice, as Maurice said. Señoras y señores, thank you for your attention.